Hello and welcome to another episode of Clean Talk. It is 3 p.m. Eastern time on Wednesday, and that means we are coming to you live. Clean Talk is the podcast about infection prevention, and I'm very excited to have our guest today, Randall Rentschler. He is the Perioperative Service Director at Artesia General Hospital in New Mexico. Randall, welcome to the show.
Thank you very much. I'm really proud to be here.
Well, thank you very much. And Randall is also a member of the Seal Shield Healthcare Advisory Council. And so in some ways, he may have been obligated to do our show today, but we really appreciate him being here and being a part of the Seal Shield Advisory Council as well. Randall, why don't you give us a little bit of your background for our audience, how you got involved in healthcare and how you ended up at Artesia?
Well, that's a long story. I've been in nursing for a little over 40 years. I started in 1979 and going to nursing school in Las Cruces, New Mexico. I had been going to school for about 2.5 years and just about a semester out from getting my bachelor in psychology and trying to figure out what am I going to do for a living with that. And I realized I was going to be a radio sac sales manager with that because you really couldn't use it for anything else. I wanted to be a clinical psychiatric nurse. And when I went to my first clinical psychiatric student nurse rotation, I realized that wasn't for me. So I really enjoyed the medicine and decided that, well, maybe that would be still an outstanding opportunity for me. Trying to get into nursing was interesting. What am I going to do as a middle-class white American male back in the late 70s to get that step up, to get that next opportunity? And so I looked at nursing, and one of the reasons that I chose nursing is I could be a minority, which is a really unique situation for a middle-class white guy. And so that helped me to make that decision. My grandmother was a nurse, and it just seemed like a good opportunity. It was interesting that back in those days, there was very few male nurses. It was about 98% female still. And even currently today, it's still about 94% female. So there's lots of openings. I think males are making headways into nursing. And I think that will change the dynamics of the field going forward as far as being the breadwinner of the family and that type of stuff, as opposed to a female using it as a secondary income for a family. I think those concepts are changing.
Yeah, I agree. And so in some ways, you're a pioneer in the nursing space. I know you've been doing this for close to 40 years. How did you end up at a mom and pop hospital like Artesia General?
Well, I started my career out in Las Cruces, New Mexico, and worked ICU for 3 or 4 years and went to their OR there. And then ended up in Santa Fe, New Mexico for about 14 years in their OR there. And I was an assistant manager, a unit manager, and just a neural unit coordinator. And then I had the opportunity to become a traveler. And so we traveled around the United States for about 3 years in an RV and worked at various hospitals around the world or around the United States. We ended up in Fresno, California, and started working at a level 1 trauma center there. And we liked the area. They offered us more money than the travel company was paying us at the time. So it looked like a good fit. I did about 5 years with Clovis Community System in Fresno. Kaiser Permanente had an opening for an assistant manager. They gave me the nod. I was an assistant manager for a year. And then I was promoted to the manager position. Then 4 years later, I applied and became a director for them. And I did the next 5 years in the Bay Area, up in the San Francisco Bay Area, as a director for Kaiser Permanente. And about that time, my wife's father was diagnosed with a terminal illness, and she wanted to be back close to him. And I understood that. We had family here in New Mexico. I grew up in Alamogordo, about 100 miles from Artesia. And so we chose to move back so we could be near family. Roswell is about 40 miles north of us, where all the aliens were first born. And then Carlsbad Caverns is south of us about 40 miles. So we're between the bats and the aliens.
So you're the hospital that services the aliens. Have you had any alien patients?
That'd be us. It's kind of interesting. There's corporate hospitals in Roswell and corporate hospitals in Carlsbad and in Hobbs. A lot of the communities aren't that impressed with their corporate hospitals that are in town. So we are really that mom and pop hospital. We're a standalone. We are not affiliated with anybody. We have the opportunity to provide just outstanding care to our community members, our friends, our family. And it really feels like that when you work here. This is a really friendly, well-run facility. We are We have top of the line equipment. It's just a really nice place, and they really are open to looking at different ideas and how to proceed with that, and they've given me a lot of leeway to implement different things on infection control or surgical approaches. So it's been really a good marriage.
Well, you mentioned that you have top-notch equipment, and I know you do. That's why I wanted to have you on the show today, Randall, and that's what we want to talk about. I know that you do a great job of identifying solutions, technology solutions, vetting them out and implementing them. Even though Artesia is a small hospital, you guys really do have state-of-the-art equipment, and that's what we want to talk about today, particularly from an infection control standpoint. But I know one of the devices that you've implemented is the Mako robot from Stryker for surgery. Can you tell us a little bit about that before we get into infection control? And is there an infection control benefit to the surgical robots?
Well, I don't know if there's an infection control benefit, but certainly what we do, we have a Stryker Mako orthopedic robot. We do total joints with it. We do total hip replacement, total knee replacement, and uni knees, and we use it for all three of those. We are the most senior robotics team in New Mexico for surgical robotics for orthopedics. They got the system late in 2015, and we do about a third of our total joints with it. We're doing about 26 total joints a month. Between two orthopods, and for a town of 13, 14,000 people, that's pretty remarkable. And we consistently do that all year long. So we do 260 to 300 total joints a year, and that's because we service all these other communities, because we have such a good reputation in the southeastern corner of New Mexico here. So it's been kind of fun to be. Albuquerque got their robot last year. We were smiling. So
that's right. You're on the bleeding edge, so to speak.
We were.
And I want to talk about some of the other technology you have implemented. Last week on our show, we had Mary Alice St. Clair with Halosil. And the first time I had heard about the Halosil project was in our Healthcare Advisory Council. You mentioned that you're using it at Artesia, and I was not familiar with the technology. And frankly, I'm pretty excited about the technology. Mary Alice talked to us a little bit about it last week, but what can you tell us about how that system has worked for Artesia? And maybe first, what type of vetting process do you go through before you implement a system like this in your institution?
Well, I think you have to look at your background. What have I been associated with? What I've been exposed to, even at these big facilities. Kaiser Permanente is this huge conglomerate, right? Northern New Mexico had 23 facilities, and that's just a huge, huge conglomerate. So I had the opportunity to learn a lot about infection control working with them. They were pretty much already going down the path of total room disinfection with UV robots. And we had the opportunity to bring in a gentleman with a Halosil system and talk to us about total room disinfection. And I really thought it was better technology. I was limited in what I could implement there. The way the political structure was, and the facility service director had already put all his eggs in the basket for a UV robotics for the OR. And so that's the way we went. So as I came down here, it was one of the things I really thought was the technology you wanted to use. It's cost effective for a small hospital. It's one thing if you have really deep pockets, Kaiser Permanente does. It's a different situation in a mom and pop hospital out here in the middle of nowhere, really, to be able to provide that type of service. So we brought the system in. There's challenges with the system, I would say. One of them is you need to be able to seal off your rooms. And the dwell time is about 2 hours. So you can run a system and close the room off for about 2 hours. It works pretty well with us here based on our surgical load. And we can easily shut down 2 rooms at a time, fog 2 rooms at a time, and then have the other 2 rooms available for trauma or for cases that we still have pending. And then we use our HVAC system just to be evacuated out after the appropriate dwell time, and we go back in. There's monitors and stuff you watch. You have to be careful walking into a silver ion and hydrogen peroxide, dry mist. You don't want to be breathing that. So there's safety precautions you have to take about it. It's kind of interesting. We really challenged the technology when we first got it. They have test strips, and we would hide those test strips in little nooks and crannies all over that room to see if it was killing. those test strips, and it was absolutely showing chemical response at the test strips everywhere. There was an issue with it. We did ATP testing on the room afterwards as well, because we're doing ATP testing on our scopes for GI world, and we were getting very low numbers. It was just amazing that we had no bacteria that we could, or at least protein on ATP, that we could pick up in the rooms. It was pretty remarkable. So we were really impressed with it. So we set up a program. Actually, I met Kristen Davis at a seminar, and I didn't know he was with Seal Shield or any of that. And we were talking, and we talking about what I was doing with Seal Shield with the Halo system, and then I had already bought a UV oven from a competitor of Seal Shields, and we were using that to do handheld devices that we use. And we talked a lot about how I was using the fogging system, and he thought it sounded like it was just perfect, to help prevent colonization of those ORs with bacteria. So we've been using it for over 5 years now.
Well, I agree. I think it is a great solution. Maybe not a perfect solution because of the challenges you mentioned, having to seal off the room and the dwell time. Is there a typical time interval that you're doing the rooms on? Is it, between surgeries? Is it every week, every month?
We typically do all the rooms once a month. About 1,800 square feet is about the maximum we can get. So our equipment room is 1,800 square feet, and its dwell time and run time, obviously, because it's such a bigger room, is about 3.5 hours for our big storage room. We do all our rooms about once a month, and that was just an arbitrary number that we came up with on how to use this and how frequently to do it. It takes quite a bit of effort and staff time to put it together, get it going, clear it up, put it all away. So we were trying to be realistic about its use. Then COVID came out, and we figured out pretty readily that we could use this for whole room disinfection post-COVID, because really there was very little information about how long the virus was on surfaces. If you're in there the next day, were you going to have a problem? Even with terminal room cleaning and stuff, you really don't know what's been touched or not touched in reality. And so we started using it after any of the COVID patients we had that we would do in the OR. Now, we've only done 4 or 5 surgical cases that were COVID positive, but we actually sent it out to various places where they felt like the room or the area was contaminated for the facility. We have, offsite medical office buildings, and there were several times we actually sent our fogger to different areas and figured out the square footage and fogged those areas for them so they were feeling more comfortable. Certainly over time, we realized that it's probably not, the virus is much weaker than what they thought it was originally, but we still run the Halo system once a month, and then after every positive COVID test, just to make the physicians primarily more comfortable about having their next patient in that room, and the staff more comfortable that they're in there, because there's, it's hard to make people feel comfortable about COVID still, I think.
I agree. You mentioned a couple of things that I find interesting. And of course, Seal Shield is in the UVC business. And I know that Artesia uses the ElectroClave UVC disinfection system for devices. But, a lot of people don't understand why UV light can be so effective for some applications and less effective for other applications. You said that you were using a UV robot in the surgery center and then in the OR, and then ultimately switch to the Halosil system. From your perspective, why is UV good for device disinfection, but maybe not ideal for whole room disinfection? Why would you choose the Halosil system over a UV robot, for example?
Well, I think shadowing is the big problem you have with UV. I think that's the number one problem with UV. I think there's a lot better ways of technology that will come out in the future for UV use for whole room disinfection. Right now, robotics have to be moved around. They don't move themselves. So you have to move them from side to side, and basically probably 4 corners at least in order to get the entire room. You're looking at as much time as I'm using with the fogging system by the time you do that for multiple OR rooms. The other situation was it just seemed cost effectiveness. UV robots are $125,000 at probably the cheapest one you're going to get to roll into an OR. $250, I think they were looking at the ones in Kaiser system. The Halo system was $20,000. We spend about $4,000 in chemical a year. That's pretty cost effective for a small hospital. So those are some of the reasons that we went down that road.
and more effective in those nooks and crannies you're talking
Absolutely.
about. You mentioned the shadowing. That is probably the biggest limitation of UVC whole room disinfection, that you have to address the shadowing, and that can be difficult or even impossible.
And I think it is
at times.
impossible.
Yeah.
I mean, if you think about all the places that there's no way to get UV to, what I'd like to see them come out in the future, and there's companies that are doing this now. You can replace your ballasts and your whole fixture, light fixtures for fluorescence with a UV system. The problem is that right now they're requiring you to replace the fixture. That's really challenging for most small ORs, because you can't really shut an OR down for construction reasons in order to replace a fixture that has the bulbs that have different strength UV in them. They have a low and a high depending whether somebody's in the room. And I think somewhere down the line, you'll be able to get UV light fluorescent bulbs that are one-to-one replacement for what you have. And I think that'll be a big step forward for whole room disinfection with UV. I just don't think we're there yet.
Yeah, and again, if you have fixed fixtures, you're still dealing with shadowing issues.
You are.
You know, we're excited about the 220 nanometers, the frequency for UV light that can potentially be safe to human consumption, but still highly effective against pathogens. And there's a lot of development going on in that space now that may lead to the kind of solutions you're talking about, where it can just be going on all the time and constantly disinfecting. What other, future do you see for UV?
Well, certainly, I mean, we use the ElectroClave for all of our iPads. We have an anesthesia program called eye procedures, and that's what we use between every patient. We have about 10 of them, so we rotate them through our EV or UV oven, our ElectroClave, on a daily basis. And then everything is done on the end of the week just to make sure that we haven't missed anything. And I think those are the big things that we'd like to see. I think that, again, the floors, there's a lot of places for UV that are coming to effect. I'd like to see our floor, med-surg floor, get a UV ElectroClave. There's several places I think that could benefit from it. I think really you see blood pressure machines in Walmart and stuff. Why not have an ElectroClave in a Walmart that's free to use for the general public to throw their phone in and have it disinfected in 60 seconds? What a deal, right? It'd just be a nice thing to be able to do for people and have them help to understand why it's important to keep, everything clean around them and be aware of how dirty a phone is, for that matter, that they've carried around for the last 2 years.
Well, it's fortuitous that you reference Walmart. Randall, I'll tell you that Walmart has started standing up Walmart medical centers, where they have physicians' offices, optometrists, dentist offices, and those Walmart medical centers all use the SealShield ElectroClave for exactly the purpose you're talking about. That's right.
But
so
not in Artesia, New Mexico yet.
not yet. It's coming to you soon, I'm sure.
Oh, good.
So so that's great. And I think the differentiation that we're talking about with UVC disinfection is whole rooms. You have a lot of challenges, particularly around shadowing. When you're doing device disinfection in a contained chamber, you can control all of that. So the ElectroClave gives you 360-degree disinfection with no shadowing. And in a small chamber with small devices, that's something you can control, and UV is a highly effective disinfectant. So,
and I think there's a good marriage between the two systems and the way we use it, and I think my infection control nurse is really excited about what we've done. I've brought her involved in it. She's aware of how we do this and why we do it. And people reach out to me from my facility and local surroundings asking me about how we're doing this and why we're doing it. So we've been really proud about what we've brought to the facility and how we use that type of equipment and the support that we get from all our vendors, whether it's Mary Alice out of Halosil or yourself or Christian Davis from SealShield. I mean, Christian really helped me a lot with trying to get an ElectroClave here. We're having problems because, again, we're a small mom and pop show, and COVID was hitting hard, and we're trying to buy an ElectroClave and upgrade what we have so we can do more devices. And we're not just a small mom and pop show. I mean, and you have somebody like Kaiser that's a big pocket money. It's much easier just to send a lot of product to one of those companies than cut out a little one for a little facility like this. But SealShield supported us, and I was really, really happy about that.
Well, I'm happy about it too, because you may be small, but we're very impressed that you stay on the cutting edge. Are there other technologies specific to infection control or new processes and procedures, best practices that you can share with our audience? What are some of the other things that you do there at Artesia?
Well, certainly, somebody's torturing me. Certainly what we do, like with COVID, is a big deal right now across the nation. So we test all of our patients within 48 hours prior to surgery to see if they're positive for COVID. With Omicron, we've had a lot of cancellations where people don't know they're positive and they're first swabbed and caught by us, and then we cancel their surgery, unfortunately for them. But you want to look at outcome, and people that have had COVID need to have a 6, 7, 8 weeks post exposure or post course of illness to have a good outcome from surgery. So we're aware of that, and we really try to push that concept, and our surgeons support that. We get a positive, they will reschedule them, but they know based on the literature out there that we should wait 8 weeks before we put them back on the schedule so they have a better chance and a better outcome from their surgery. Because doing surgery is about making people's lives better. It is, as an ICU nurse, I think I probably tortured people. I would tell you, just the way you feel about it when you have somebody that's long-term bent, in surgery, you get people better. You do a procedure, they get better, their quality of life improves. And I think that's really important. And I think that's why I'm so proud to be a surgical nurse and to have influenced. I think as you get into my realm, I started out as an OR nurse or an ICU nurse, and I could provide incredible care to a single human being. As I expanded my influence as a charge nurse, a assistant manager, manager, director, it allowed me to influence people's care of patients that were under my umbrella. And I think that's really important to do. So you help to bring that upcoming generation in and help them understand how important it is to try to give that high quality patient care to every one of them.
Well, it's a powerful mission. And you mentioned outcomes. Is it too early to talk about the outcomes and the benefits you've seen from some of the technology that you've implemented?
Well, I think it's probably hard to see. I think there's benefits there. You don't know how many infections you've averted that you didn't occur because of your cleaning techniques, how you decide to clean the autoclaves. I mean, use the ElectroClave for iPhone use or iPad use. And so you're bringing less contaminated product back into the OR. The Halosil system, disinfects the entire room, so your room's clean to start with. We certainly do terminal room cleaning based on the RN standards. We flood the rooms and wet back them. And I mean, we do all that every single day anyway, as part of just the routine care that we're going to give. An OR requires a lot of indirect patient care. Certainly patients are what we're about, but if you're not doing that indirect patient care, you're not providing a quality product, whether that's an arthroscopy or a total joint. You just have to look at giving them a complete package to know that they're safe under your care in an operating room.
And not just the patients, your fellow practitioners, right? Particularly when we're dealing with a pandemic, your coworkers are exposed to more things on a daily basis. Are there any processes or procedures that you've put in place as a result of COVID to better protect your fellow practitioners?
We did a lot of stuff. Certainly the first wave was coming through. We actually developed and there's a lot of literature on this. We actually developed both a clean and dirty hallway for the hospital. So only COVID patients would come through the dirty hallway, and only clean patients would come through the clean hallway. We were in the same boat as many people were and had gone on some sabbatical for surgical procedures, for quote elective surgical procedures. But as that lightened up and we started doing surgery again, we put in we made our whole med surg unit negative pressure. Instead of having a negative pressure room, we had a negative pressure unit. We put in doorways to help maintain those negative pressures. And I think that really helped to keep the cross contamination that you might have seen potentially from occurring. So we were really very rigid about what direction of travel you could be, whether you had a positive COVID patient or if you had a quote clean patient.
Well, you mentioned that that the outcomes of performing surgery on a COVID positive patient, that their best outcome is if they wait 6 to 8 months, I think you said.
6 to 8 weeks.
6 to 8 weeks, 6 to 8 weeks, of course, before they get that procedure. We do have a question that's come in, and they said, have you ever performed surgery on COVID positive patients? That's happened, right?
Absolutely. We've probably done 4 or 5 in the last 2 years. Again, we're a small facility. People still have to have surgery that have COVID. And we've done 2 bowel resections and I think 3 appendectomies on people that have had COVID and are current with COVID. And I will tell you that they all have had good outcomes at this point. And one of them is one of our local employees, and they've done just outstanding. They finished up their COVID course and healed from their appendectomy. They had a laparoscopic appendectomy and did well, and they're back to work and smiling.
Well, that's great news and good to hear. And yet you've put these procedures in place now to identify when a patient does have COVID so that if it's not an urgent surgery, right, then you postpone it.
That's right. Because there's, you worry about hurting that patient on their outcome as well, but contaminating other staff. And they've found COVID in smoke plume. They've found COVID in body fluids and other body fluids, not just saliva. So it's one of those things that you worry about and you're concerned about. We provide care where needed. If it's urgent to have that done, regardless of what's going on, we're going to take care of you.
But to that point, what are the processes and procedures that have come into place as a result of COVID for anyone coming into the hospital? Do you have mandatory testing for patients, or does everybody get tested? What are your processes?
We do. Everybody that's getting admitted gets tested. Everybody that's coming into the surgery, we pre-admission testing. We test them for COVID within 48 hours, 72 on the outside. It's hard to do a 48-hour test for a Monday case. So usually those are on Friday. So it's about 72 hours out from when they're tested. With Omicron, we really had to shorten that interval because Omicron was coming on in about 48 hours. So we were very concerned. Originally, we were doing about 96 hours out within the 4 days or so prior to surgery. But with Omicron, it was absolutely one of the strategies we did was we shortened that interval when we would accept testing or have to repeat testing. And I would tell you, I was really surprised on how many people that we have canceled in the last 2 months that are positive, but they don't know it because they have a subclinical course.
Yeah, and it takes a while for the symptoms to emerge, right? So right. That's what happened to me. My kids tested positive for COVID, so I took a test. I felt great, but it turned out I was positive. 3 days later, I didn't feel so great, but
that's right. Yeah.
So that's the process for patients. I know there's been a lot of confusion on some of the CDC guidelines for healthcare workers. What is Artesia doing in terms of testing or vaccination policies in the hospital for practitioners?
Well, we follow the CDC guidelines. We're requiring all medical personnel to be vaccinated, including boosters, and we're going through that validation right now. There are exceptions that are allowed at any facility you're in, either religious or whatever personal exception that you can speak to well enough to get it accepted. So we've been doing that for quite some time now. And I would say I probably have 2 people that are not vaccinated, but they're tested weekly. When we first started with COVID, we were testing the entire surgical team twice a week. So everybody was going through twice a week getting tested for COVID. And then that slowly but surely graduated out to about once every 2 weeks. We never caught a person on a pre-screened COVID test for the first, we tested for 8 months before we quit testing surgical staff every 2 weeks. And it was surprising we never caught anybody. We'd catch them on symptomology. That's how we caught somebody that was positive. We'd never caught them ahead of time that, oh, you're positive, you need to go home. It was always, we knew they were having symptoms, get them tested and they would be positive. So it was pretty interesting to do. But anytime we have anybody has any symptoms at all, we have a system that we put in, the electronic system, we can put in a request for a COVID test on an employee or a family member of an employee. And that's done by the next day and we get results that afternoon. So we're pretty forthcoming about making sure people are clean and careful and able to work without causing a cross-contamination.
What other changes have you seen in the facility as a result of COVID, either in the way that you select products for infection control or just in the general operations of the facility? What can you share with our audience?
Well, I think early on, we had pretty much stockpiled quite a bit. We have a pretty sharp materials manager, and she really stockpiled gowns, stockpiled gloves, stockpiled masks and stuff. So we didn't have a lot of the challenges a lot of the places in the country were having because we had product available. Biggest problem you saw is, and even currently is the supply chain, right? So we've had challenges with FedEx or with UPS getting out because of COVID problems with their own staff and getting deliveries made. I think that's improving slowly here with as the COVID numbers are dropping dramatically nationwide currently. So we're having less problems with that. But that was something that we looked on early on that we were looking at. You would have to change manufacturers, change suppliers just to accept product that we might not have accepted earlier on the previous years as not quite adequate or not something that wasn't is acceptable as it might have been to a physician or a surgical provider, and realize that sometimes you get what you can get and you do the best you can with it and make it work.
Absolutely. Well, as a cutting edge practitioner, is there anything you can share with our audience where you've seen significant results or best practices or tips and tricks around infection control? Where's the most bang for the buck that people should be looking into if they're watching right now?
Well, I guess it depends on what you're looking for as far as what surgical procedure you're having. Certainly looking at making sure that you've checking your patients for not just COVID, but for MSRA, so you do nasal swabs and help to make preventive so that you're not doing something that's already colonnated and it causing you a problem down the line. You worry a lot about cross-contamination.
I'm sorry, I just wanted to interrupt you there. So the MRSA testing, do all patients get MRSA tested? Is that a policy?
No, we prophylactically treat all MRSA patients. So they have like betadine swabs and stuff that you do in their nares for all the total joint cases, just to help prevent that colonization from causing a problem and having a wound problem later on, having an infection later on. Nosocomial infections are a concern for any facility. And so we're aware of that. We watch that. I don't know that it changed our antibiotic use at all. I don't think that it was really something that we worried about. We follow the standards from AORN and from the American surgical societies as far as what we're using and stuff. Sorry.
No, that's okay. Well, I know you guys are using best practices for infection control. Super impressive for a small facility. Is there anything in particular that you've seen the best results out of that you would say, this is a game changer, this is making a difference? Anything you can share with our audience there?
I think the ElectroClave is probably the simplest thing that we implemented that I think makes a difference. I have my staff put their keys in it, their badges in it, their phones in it. We use it for the iPads. I think is the easiest technology to implement that doesn't cause stress. I mean, there's no training involved in it. Go up, badge into it, put it in, it'll beep, take it out, you're done. So I think that was probably the best technology I implemented.
Well, I certainly appreciate that endorsement. SealShield appreciates your endorsement of the ElectroClave, and we appreciate you being on our Healthcare Advisory Council. You've been a great member. Looking forward to sharing more best practices with you to make healthcare better. Really excited to have you on the show today, Randall. Thank you for joining us. You've been watching Clean Talk. Join us next week, Wednesday at 3 p.m. for another episode of Clean Talk. Until then, for my guest, Randall Rentschler, I'm Brad Whitchurch, reminding you to keep it clean.